Hello, this is Dr. Tony Clark with learninganesthesia.com, and today we're going to talk about NPO guidelines and aspiration and what medications affect lower esophageal sphincter tone and what medications affect gastric acid production and volume. So first off, we're going to talk about risk factors for aspiration. Essentially, risk factors for aspiration include any condition in which gastric emptying is delayed, intra-abdominal pressure is increased, or lower esophageal sphincter tone is compromised. So I'm going to put decreased gastric emptying, an increase in intra-abdominal pressure, or a decrease in lower esophageal sphincter tone. Things that are going to decrease gastric emptying are chronic diabetes, chronic opioid use, trauma, any neurologic condition. That decreases gastric emptying. The big thing with diabetes is if a patient has diabetes but it's very well controlled, then gastric emptying may not be decreased. But if they have poorly controlled diabetes with autonomic symptoms or peripheral neuropathies, then gastric emptying most likely is decreased. Other risk factors are things that increase intra-abdominal pressure. That would be pregnancy, ascites. Another thing that may increase intra-abdominal pressure and delay gastric emptying is bowel obstruction. And then other things that increase lower esophageal sphincter tone, pregnancy is one of them, severe GERD, hiatal hernia. It's not a complete list, but those are the things that you would think about being called a full stomach. So let's say that you do have a patient that aspirates. What should you do? You have induced the patient for general anesthesia, and they do aspirate. The ideal thing is to put them in Trendelenburg position, suction the mouth, intubate, and suction prior to giving positive pressure ventilation. Followed by bronchoscopy. Lavage is not indicated, but bronchoscopy and suction out anything that they may have aspirated. Things that make aspiration worse are pH less than 2.5 and volume greater than 25 mLs. So if you have a patient that aspirates, typically they complain, cough, they may have some wheezing, dyspnea. This may lead to aspiration pneumonitis, which is a chemical reaction from the volume and the pH of the solution that they aspirated. Again, a pH of less than 2.5 and a volume of greater than 25 mLs is going to be more severe. They'll complain of cough, wheezing, dyspnea, may require oxygen, fever, tachypnea, and may have even an elevated white blood count. With all this, they may have chest x-ray findings that show aspiration pneumonitis. However, they do not need treatment with antibiotics yet. If the fever persists, the white count persists, and the chest x-ray continues to worsen over the next several days, that leads to aspiration pneumonia. This is typically 48 to 72 hours later. Fever, elevated white count, tachypnea, and the chest x-ray worsens or fails to improve. This, you would start antibiotics. Your most common organisms are going to be Haemophilus influenza, Streptococcus, and anaerobes. So how do we prevent aspiration? Well, one of the big things that we do to prevent aspiration is our NPO guidelines. We ask that the patient be fasting for any elective surgery. Again, if it is a trauma patient, even though they have been fasting because it's a trauma, still considered a full stomach. Our NPO guidelines are broken down into fasting of 8 hours, 6 hours, 4 hours, and 2 hours preoperatively. For elective surgeries, patients are required to fast at least 8 hours for a solid meal. Or any meal that contains fat in it. 6 hours is required for a light snack, such as crackers, toast, and cow's milk, and formula. 4 hours is required for breast milk. 2 hours is required for any clears. This brings up multiple points. If a patient has had dark coffee but has had creamer in it, that technically counts as a solid meal since it has high fat content. Or if it had milk in it, it would count as a 6 hours. Since cow's milk, you have to wait 6 hours. Breast milk comes up a lot in testing and examinations because it's easily confused with cow's milk. Breast milk, you must wait 4 hours. One way that I remember this easily is that breast milk is natural, therefore it is digestible faster versus infant formula, which is synthetic, and so the stomach takes a lot longer to digest it. I'm not saying that's necessarily true, but it's just the way that I think about it in my head. What else do we do to prevent aspiration? Well, if a patient is considered a full stomach, we do a rapid sequence induction. What that means is we use drugs that act rapidly and we secure the airway rapidly without mask ventilating. Typically, we use a rapid-acting sedative such as propofol, etomidate, or ketamine, followed in sequence by a rapid-acting neuromuscular blocker, succinylcholine at 1 to 1.5 milligrams per kilogram, or rocuronium at 1.2 milligrams per kilogram, and no test ventilation prior to intubation. The other thing that we do, evidence is for and against it, is cricoid pressure. Cricoid pressure is direct pressure at the cricoid cartilage. It's a downward pressure. The theory is that it occludes upper esophagus. There are drugs that you can give if you're worried about patients having an aspiration event, but the ASA does not recommend routine use. But we'll go over the different medications and how they work. First, the most common one used are antacids. Typically, we use Bicitra at our institution. It effectively raises the pH. Because remember we said a pH of less than 2.5 is a risk factor for developing aspiration pneumonitis and aspiration pneumonia. You can give H2 blockers like cimetidine or proton pump inhibitors like omeprazole, but they take a little bit of time to work, so they must be given far enough in advance. They will increase pH as well and may decrease gastric volume. Metoclopramide is another drug given. It's a dopamine antagonist, and it decreases gastric volume and increases the lower esophageal sphincter tone. It decreases volume by increasing gastric emptying. But since it's a dopamine antagonist, you do not want to use this in patients with Parkinson's disease. Let's move on now to things that increase or decrease lower esophageal sphincter tone. This is commonly tested. Drugs that increase esophageal sphincter tone are succinylcholine, fecuronium, metoclopramide, and neostigmine. Things that are going to decrease esophageal sphincter tone are your parasympatholytics. They are parasympathetic inhibitors. Anything that inhibits the parasympathetic nervous system will decrease the lower esophageal sphincter tone. Opioids, especially high doses and chronic use. Thiopental, volatile anesthetics, NG tubes, and LMAs. Pregnancy as well. Those are common things that are tested and things that you should definitely be aware of that increase and decrease lower esophageal sphincter tone.